Hello, my name is Craig Coopersmith. I'm the director of the Emory Critical Care Center. I'm sorry that we can't all be together today, but I'm looking forward to talking to you virtually about the keys to successful rounds. You see my disclosures here. I have roles in the Surviving Sepsis campaign, and I was a co-investigator on two recently concluded clinical trials for which I was not paid. So the first and most important thing to remember when we talk about successful rounds is who must be the focus of rounds. And I'm always amazed when I ask this question if somebody says anything other than the patient, because of course the patient should be the focus of rounds. And when the patient is the center of rounds, everything should work well. However, that does not mean, of course, that everything does work well. So what are the keys to having successful rounds? Well, after the patient, who should be on rounds? Of course, the doctor should be on rounds. And while the patient and the doctor are a good start for successful rounds, clearly the patient and the doctor are not enough. So who else should be on rounds? Well, the nurse should be on rounds. And these are nurses in one of the ICUs that I work in. So the patient spends 100% of time with themselves. Depending upon the size of your ICU, the doctor might spend as little as 5 or 10% of their day with their patient. And depending on staffing, which I understand varies between countries, the nurse spends anywhere between a third to 100% of their time with their patient. And so on a second-by-second basis, the nurse has a much better idea of what's happening than the doctor. The nurse also very likely knows their patient as a person much, much better than the doctor does. So who else should be on rounds? Well, the multi-professional team. And this is a picture of our multi-professional team. So who's on the multi-professional team? Once again, it depends upon your ICU, the structure, your culture, and your country. There's many options, and the more of these are better. These are things that we have in the United States. We have APPs, nurse practitioner and physician assistants, pharmacists, respiratory therapists, a dietitian and nutrition support, social workers, or spiritual support and chaplains. Everybody on the team has a unique expertise, and everybody has a perspective that can improve the quality of rounds and patient care. So what's a high-functioning team? A high-functioning team, everybody knows their role. Everyone performs their roles to their best of their ability every single time. A team trains together, and everybody respects their teammates. Nobody is more important, nobody is less important. An ICU cannot function at its highest level without everybody doing their job at the highest level. And an ICU cannot function at its highest level without mutual respect. So here's a picture, and I give credit to our hosts in Brussels, of a highly functioning team. And so we see a highly functioning team. It's important to recognize that everyone is the best of the team at what they do, but not at everything. So to use the football example, the striker is the best striker, but not the best goalie. The goalie is the best goalie, but not the best midfielder. Everyone has the role. It's the same in the ICU. I'd like to believe I'm a good doctor. However, I'm not a good nurse or pharmacist or respiratory therapist or chaplain or social worker. Each of us is the best at what we do. Each of us should practice to the highest extent of what we can do. And together, with respect, that truly makes us a team. So, what's my name? I understand that what I'm going to say might differ from some people listening to me because there are certainly different cultures. I call every one of our nurses, or just about every one of our nurses, by their first name. I call our pharmacist by her first name. I call our respiratory therapist by their first name. I call every other member of the ICU team by their first name. So what does it say to a group of colleagues? Every single one who went to school, every single one who is a professional, if I call them by their first name, and yet they call me Dr. Coopersmith. That's not a team of equals. That's not a team anymore. That's elevating me above the team. So what's my name? My name to my team is Craig. It's not Dr. Coopersmith. If I call you by your first name, you call me by my first name. On the other hand, what's the name of my patient? Again, I do understand this varies between cultures, but I call every one of my patients Mr. or Miss or Mrs. I never call a patient by their first name unless I'm specifically told to. I don't call them by their first name. I don't call them by a nickname. I don't call them dear or honey. I call them Mr. or Miss or Mrs. This is a sign of respect. They did not pick me as a doctor, since one basically never picks their intensivist as a doctor. And I did not know them prior to the ICU admission. This is different from your general practitioner or your cardiologist or your gastroenterologist when you could say, I'm choosing to go to Dr. So-and-so. Somebody didn't choose me, they got sick, and now I'm their intensivist. And so as a sign of respect, I call them by their last name. And if I expect them to call me Dr. Coopersmith, which to be fair, I don't really care about, but just about everybody does, it's appropriate to be formal with them as well. So who else should be on rounds? Well, the family. The family? So the family of the patient is scared, is tired, is stressed. This is likely literally the worst time of their entire lives. They almost certainly have little understanding of what they've been told, or even if they do understand what you tell them, it's likely they won't remember it. And so making the family part of the team drastically improves their experience in the ICU. And actually, it can also improve patient care. First of all, families are nearly universally thankful that they're a part of the team, that they hear what's going on, that they can ask questions, and that you're not hiding anything from them, that they're really part of the patient's care. Sometimes they'll tell you something important about the patient that you do not get in the medical history. So somebody may or may not have talked to the patient may or may not be able to talk, they might be intubated. The family's lived with them for years or decades, and they can actually tell you about their history, especially pre-hospitalization, and they're often correct the resident. The resident will sometimes tell you something that they were told secondhand, and it might not even be correct, but the family can actually correct it. So, what time should rounds start? So rounds need to start the same time each day. It doesn't matter what time that is. It can be determined within your institution. However, it can't be a different time each day, and it can't be a different time each week. It can't be that Dr. A starts at 7:30 and Dr. B starts at 8:30, or that Dr. A on Monday starts at 7:30, and on Tuesday, they've got to go to clinic, and so they start at 9:30. It has to be the same time each day to be respectful of your teammates, to be respectful of everybody in the ICU, to be respectful of the families who will join you in the ICU, except of course during the time of COVID. A standardized approach is superior for all members of the multi-professional team and for patients, and when families can join us. Again, not during COVID, the families as well. So next, flow of information is critical. The daily plan must be understood by everybody, and information transfer can be done well, it can be done poorly, or it can be done not at all. So what's the worst? The worst is saying nothing. The team is not made up of a bunch of mind readers. If you do not clearly state what the plan is, nobody knows what the plan is. You have to clearly state the plan. But there's other ways to be bad. You can talk and talk and talk and talk and talk, but if you don't ask to make sure that what you've said is understood, it's quite possible that even though you think you were being clear, that the team didn't actually hear what you were saying. So what's needed? First, we have to have a reiteration of the daily plan and/or order readback. Just because something is said does not mean that it was understood. Mandating that somebody repeats back and that orders are read back drastically decreases the risk of errors. Again, I can think I'm being totally clear, but if the person listening to me did not understand what I said, I was not being clear, and the patient will either not get something that they need, or they'll get the wrong thing. So what else is needed? A to-do list. A to-do list can be electronic if you've got the technology. It can be written as long as it's clearly visible and understandable, but it cannot be optional. So here's actually one of the walls of our ICUs. So you actually see our goals for the day, and you can actually look line by line and say, as simple as this isn't electronic, we literally write on the wall, but then we could check off each box for the day. So what else is needed? A daily checklist. So which of these things are exciting? DVT prophylaxis, stress ulcer prophylaxis, antibiotic stop dates, which catheters are in place, if physical therapy is working with the patients? None of these are exciting. I guarantee that none of you go home and say, it's so exciting. I asked whether or not my patient has stress ulcer prophylaxis. But which of these potentially decreases morbidity and mortality? Actually, every single one of them. It's easy to focus on the life-saving things, ventilators and pressors and codes and the such. And if you do so, it's easy to forget the quote-unquote routine parts of ICU care. And because it's easy to forget the routine parts of patient care, a checklist mandates that you go over each of these elements each day to assure that you don't forget anything. I've previously shown you this picture. I showed you the top for the goals to do, but now look at the bottom. And the bottom, you actually have our checklist that we go over each day. Tells you what is the VTE prophylaxis, what is stress ulcer prophylaxis, is physical therapy working with the patient, what antibiotics they're on, and when do they stop. So how long should rounds last? And the answer is not too short, but not too long. Rounds that are too short because you just want to move on to the next patient are not acceptable because there's inadequate transfer of important patient information. Again, if you're not being clear to your team and they're not understanding what you're saying, patients will suffer. But if everybody is yawning or finding reasons to walk away or playing on their phones, rounds are too long. There's no ideal amount of time to spend per patient or per ICU. Of course, it depends upon the acuity of your patients and the size of your ICU. But the goal is that you have a similar approach to all patients, excepting, of course, bedside teaching. And if you work in an academic medical center, there's going to be learners, all kinds of learners, MDs and APPs and nurses and pharmacists, all kinds of students and all kinds of professionals at various levels. So how do you teach on rounds? From the standpoint of the trainee, the one who's learning, rounds can be educational or a waste of time. They can be terrifying or they can be welcoming. They can be interesting. They can be boring. And they can be a role model for what we want our trainees to aspire to be, or they can be a role model for what we don't want our trainees to aspire to be. So there are many ways to make rounds horrible for learners. You can be pompous and make it clear that you're better. You can yell at your team. You can talk and talk and talk and talk. And every one of those is not appropriate. So how do current trainees learn? They learn by interaction. They learn on rounds that are welcoming, that are team-based, that are repetition. Understanding that I'm lecturing to you right now, they don't learn by lecture. And they certainly don't learn by making people feel stupid or afraid. Ultimately, rounds should be efficient, rounds should be educational, rounds should be professional, rounds should be interactive. And despite the very serious nature of what we do, rounds should be fun at all, if at all possible. Thank you so much for the invitation. It is an honor to be here. I look forward very much to seeing you all in Brussels sometime in the near future when we get past the worst of the pandemic. Thank you.